Hello, my name is Colleen Johnson, and today I am going to present my outbreak case study on the 2009 H1N1 pandemic. So, the pandemic started in spring of 2009. The World Health Organization declared the pandemic to be over in August of 2010. And it started officially on April 15, 2009. A 10-year-old presented with a positive flu test. That test was then sent to the CDC, and it was determined that the type of influenza that the patient had not been seen in humans or animals before. So the outbreak first occurred in California, and then it spread to the other U.S. states and then globally. The affected population, there was significant morbidity and mortality associated with the 2009 H1N1 pandemic, primarily in people younger than 65 years old, and we'll get into some details as to why that was. The CDC noted that approximately 80% of H1N1 related respiratory and cardiovascular deaths in individuals younger than 65, which was significantly higher than for those same statistics for seasonal influenza. So some risk factors for severe disease included pregnancy, second and third trimester pregnancy specifically, a BMI of over 35 kilograms, chronic medical conditions, and delayed antiviral treatment. The transmission was viral, and it was transmitted by human respiratory droplets. In the initial response efforts, the CDC activated its Emergency Operations Center, abbreviated EOC, on April 22, 2009 to coordinate the response to this emerging public health threat. And here is a picture of Julie Gerberding, who was head of the CDC during this pandemic. So some specific details in the epidemiology context are the number of cases, nearly 61 million cases per the CDC. There were over 12,000 deaths in the U.S. alone. And the first two United States cases were in children living in California and Texas. They had no known contacts with pigs. And it concerned the CDC because it suggested a new strain that was capable of spreading person to person. This is part of what led to the pandemic declaration, so it's important background. In the disease investigation, most people initially had no contact with pigs. The virus emerged through a process called reassortment, a mixing of genetic material from different flu viruses, including swine, that led to a new human strain. And then the EOC was organized into teams that had specific areas of focus. The EOC teams that were formed covered surveillance, laboratory issues, communications, at-risk populations, antiviral medications, vaccines, and travelers' health issues. And I have here a picture of one of the first H1N1 flu vaccines that launched. This is a box. And then this is a photo of the CDC surveillance team at a phone bank. And for some additional epidemiology context, I just wanted to show this when I was thinking about just how impactful and how potent and effective this virus was. We started out with one positive child in the state of California in the United States. And by 2010, so in a little over a year, this was a map published by the World Health Organization. You can see that it's virtually spread throughout the whole globe. And in addition to that, all the red dots represent countries where deaths happen from this disease. So it was highly, highly effective. In the identification of the disease, the CDC confirmed 2 unrelated cases of swine flu, is what it was initially called. It's layman's terms. And as I said earlier, there was a new reassortment of viruses put together, some previously H1N1 viruses mixed with some animal strains. And then that created a new virus that was capable of spreading person to person. Some specifics around the surveillance methods were that the WHO had, in the data collection techniques, there was viral culture, rapid antigen tests, and DFA testing that was conducted during the data collection. Some of the challenges that were faced by investigators were that, first of all, prior to the H1N1 pandemic, there were 3 systems in place for global detection and surveillance of pandemics. So they were initially operating under that framework. However, some of the challenges that framework presented was that there was some discrepancy in clinical characteristics of the virus. There was not consistent agreement on which populations were most vulnerable. And then there was an issue with the capacity of different populations in different countries and what they were capable of responding to. So what the established healthcare system was in a given country, what their pandemic preparedness was, and whether they had sufficient resources. So this is an epi curve from the initial outbreak here in the United States. This was published by the New England Journal of Medicine. And you can see just how significantly the pandemic took off when it spread throughout the United States. So, who was most at risk of severe disease from the H1N1 pandemic? Pregnant women, specifically 2nd and 3rd trimester, healthcare and emergency services personnel, those folks that were on the front line, persons aged 6 months to 24 years, and persons aged 25 years and above who had high-risk medical conditions. The attack rate of this disease overall was around 11%. Interestingly, if you take a look at the statistics and how they were spread across different age groups, it was the younger patient population that had the highest attack rate, specifically 5 to 14-year-olds. And 30 to 39-year-olds had the lowest attack rate. So in trying to research a little more about the spread and impact and the impact of some of the healthcare or health disparities that were presented through this pandemic, I went through a lot of research, and I wanted to quote this from an article that I read, and it says, quote, "To our knowledge, there has been no such study that examines the current literature while screening for and comparing possible factors contributing to health disparities among Blacks, Asian Americans in the USA during a single outbreak." And so this particular study, what they looked at is they went back and they looked at the 2009 H1N1 pandemic, and they also looked at some of the same things that were presented during the COVID-19 pandemic, and they were looking for similarities in disease spread, the epidemiology curve, etc. And so some similarities that they found between these two pandemics were multifamily households, residential segregation, poverty, exposure at work, comorbidities, or access to health care. Those all played a role in both pandemics, but specifically they were looked at in this study retrospectively when also looking at the COVID-19 pandemic. The social context, it was interesting reading about some of this because social media had not really taken off yet. And so primarily if people in the United States specifically were to get information, it was coming through network news outlets. If a household had internet, then they could get information from there, or they were able to get it from their healthcare providers. But it was interesting thinking about the fact that it was mostly professionals giving information to the public. It wasn't people that were just spreading misinformation or spreading rumors within a community or through social media, as we saw in the COVID-19 pandemic. One unfortunate happening here was that because it was initially found in a Latino population, specifically in California, where you had a lot of pork farming that was taking place, the perception was that it was a Latino disease as it was spreading throughout the United States. And then also what was impacting the social context was the amount of morbidity that was taking place in pediatric population, also mortality in pediatric population. And so access to healthcare and antivirals that were a significant tool used in this pandemic, that impacted pediatric outcomes. And I have here the impacts of this. The past of the 2009 pandemic really foretold the future of what was to come with the COVID-19 pandemic. Some of the control measures that were handled was the CDC published new guidance on the usage of antiviral medications for treatment and prevention. The CDC during this time also issued the first, quote, CDC interim guidance on closing schools and childcare facilities, end quote. And they recommended a 7-day closure when a lab-confirmed case was reported in a setting, in a school or a childcare facility. An additional control measure came to market in October, where there was a monovalent vaccine that was released and approved by the FDA. And by November 16th, 5 total vaccine products had been approved by the FDA. And by the end of December of 2009, H1N1 vaccine was widely available. 60 million doses were delivered to 65 countries by 2010. So it was a very quick and significant ramp up to make vaccines available for the general population. Who was left out in these measures? So school and daycare closures left families impacted when parents had to continue working and their child's school or daycare was closed due to the guidance by the CDC. And of course, the working class was disproportionately affected by daycare and school closures, those people that had limited access to additional family funds for babysitters, etc. Vaccines were readily available by the end of 2009. However, the groups most affected by severe disease, pregnant women and pediatrics, faced challenge with vaccine access, primarily in rural communities and those areas underserved by public health departments. And in conclusion of this case study, I wanted to put a quote that I thought was really fascinating. It was from 2009. And the quote says, "The emergence of yet another serious global health threat from an animal source highlights the critical need for deeper understanding of zoonotic viruses, including in vivo studies of pathogenesis in animals, field field epi-studies, and surveillance in animal populations, along with the development of computational models." Some lesson learned during the 2009 H1N1 pandemic. A recent and seemingly prophetic GAO report published in February of 2009 warns the continued threat of a pandemic as our national priorities move from pandemic preparedness to the economy and other issues. Current events remind us that pandemics can strike at any time and with little warning. Our communities need to stay ready to respond to such a threat. That was in February of 2009. And then another study that I read that I thought was very interesting in reflecting this pandemic. The quote was, using mathematical models versus broad community recommendations can better target at-risk populations to potentially mitigate hospitalizations and deaths. I had numerous references to support this case study. They're listed here. Thank you very much.